Hello, my name is Dr. Rutul Thakkar. I am practicing at Ahmedabad as a consultant diabetologist at AHC Diabetes Clinic, which is situated at Satada Crossroad, Katlodia. I will be discussing about hypoglycemia case today, which is very burning topic in our diabetes treatment and management. So there is a case study of poorly controlled diabetes with hypoglycemia risk, where a 50-year-old type 2 diabetic patient for 2 years, that patient came with frequent hypoglycemia events in the past 2 months. He was already on metformin 1000 milligram 2 times and glimepiride 2 milligram 2 times. His HbA1c was 8.2% with quietly fair eGFR of 88 ml per minute. His LDL cholesterol was in normal limits. His triglyceride was 126. His SGPT was 33 and his creatinine was 1.1. On physical examination, he seemed to be very much obese or overweight, we can say. His BMI was 31. His blood pressure and heart rate was also in normal limits. So optimized glycemic control with cardiorenal protection are the primary treatment consideration. An HbA1c goal for many non-pregnant diabetic patients should be less than 7% and it is appropriate. On the basis of provider judgment and patient preference, achievement of lower HbA1c such as 6.5 may be acceptable if this can be achieved safely without significant hypoglycemia or other adverse effects of treatment. In the 21st century, type 2 diabetes has reached to an epidemic proportions globally. Indians have a tendency for earlier onset of type 2 diabetes, maybe a decade earlier, and leading to an accelerated risk of developing complications, making it more essential to address this pathology early in disease course with available novel therapies having minimum risk of adverse events. Strict glycemic control is critically important in patients with type 2 diabetes. Sulfonylureas like glimepiride, gliclazide play a very important role in glycemic control as a direct extension of their mechanism of action. However, the risk of hypoglycemia is increased and this risk may be further increased in patients with renal impairment, which is common comorbidity associated with type 2 diabetes. Hypoglycemia is a major concern for users of sulfonylurea like glimepiride and gliclazide, which are commonly used drugs. Magnitude and severity of sulfonylurea-induced hypoglycemia range widely across studies. This is a strong rationale for combining a DPP-4 and cardiovascular protective class of SGLT2 in patients with type 2 diabetes because two drugs exert different and complementary glucose lowering effects. Furthermore, the increase of glucagon levels induced by SGLT2 inhibitors may be blunted by the co-administration of DPP-4 inhibitors. Clinical evidence shows that SGLT2 inhibitors and DPP-4 combination is an effective option of management of type 2 diabetes, providing a HbA1c reduction of 1.1% to maybe 1.5% and weight reduction of approximately 2 kg when added to metformin, which is its primary place in the therapy. The American Diabetes Association recommends initial combination therapy should be considered in patients presenting with HbA1c levels between 1.5 to 2% above the target. Considering absolute effectiveness of most oral medication rarely it exceeds more than 1%. This unique combination lends itself readily to early treatment intensification because of good tolerability, low risk of hypoglycemia, possible weight loss, and minimal treatment burden. Clinical experience with DPP-4 inhibitors and SGLT2 inhibitors combination show that they can be used with a good safety profile and low risk of adverse event that may be hypoglycemia and weight gain. Even when added to metformin, which is particularly important finding for clinicians. A reduction in the incidence of genital infection associated with SGLT2 inhibitors has been reported when DPP-4 is added, perhaps because of better glucose control, although other possible mechanisms remain to be investigated. Thank you.